when it comes to designing the project, the headquarters staff are doing most of the design, and then right at the end, to show that we're being participatory, we're asking the country programs, what do you think about that? So they already have projects brought to them that aren't really inclusive. When we look at the measures for success, so the indicators that are used, a lot of the indicators are to appease the donors, I want to say. They're not really, I would say, culturally important in the country. It's more X number of people received this service. For headquarters and for donors, that's what they want to see. But is that really what the communities that we're serving, is that their measure for success?
My name is LaShawn, your host for this episode, alongside my co-host and best friend, Gordon, as well as our guest.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content.
What's up, Gordon? Long time no see.
Okay.
You can't start off with the okay, bro.
Yeah, that's my favorite word.
Why?
You know why? We have a friend that has a very unique way of saying it.
No. We can't start off like this, bro.
What?
You gotta give the people what they want.
Yeah, just go with it. Riff.
Okay.
See, you just said it. All right, you trying to get serious?
Yeah, let's go.
Okay.
All right,
You know,
so what are we talking about today?
you tell me.
All right, I'll give you the little rundown here. Today we're going to be talking to someone about why she left her career in global health.
Okay. That's very interesting. I think you told me the story about coming across an article that Dr. Madhu Pai had shared on Twitter, and you got quite curious, being that you are a global health professional yourself, and I think you got a little spooked.
Yeah, I think it was a very interesting article. A lot of the times we hear about a really fulfilling career in global health, but I think it's very important to also learn about the realities and practices and essentially the realities within the global health space. And we touched on this in a previous episode back in 2020 where we actually brought up one of the reports. It was the Global Health 50/50 report. I think it was in 2020. And since then, the 2022 report came out, and we know as global health professionals, there are a lot of problematic practices and things going on in the global health space, whether it's representation of gender in certain positions of power, whether it's who's leading these global health agendas, whether we're talking about donors and donor-funded projects, who's actually setting those agendas, and whose best interests are in mind in those situations. And in terms of the places where there are the most expertise, they're also not represented in these decision-making seats. So we know this, but I'm really curious about hearing specific experiences from someone that has been at the peak of their career in a global health career and realizing all this, seeing it all, experiencing it all firsthand, and then deciding to step away. I thought that was very interesting.
Yeah, and it's refreshing because we know that since COVID-19, the pandemic, there's been a wave of inspiration for people to pursue public health, for people to pursue global health. And it is indeed rewarding and potentially sometimes thankless work. But when we hear this, like you said, the realities and the challenges are not often considered when someone goes into this. And I'm familiar with the flip side of this conversation being why someone left a career in something else to come to global health or to come to public health. So to hear from someone who left global health, what were those specific challenges? What should students and aspiring global health professionals know about the field of global health before pursuing it? That's something that I'm hoping to get out of this conversation today.
Yeah, I'm really excited. Let's get into it. Lazenya Weekes-Richemond worked in global health for 14 years, managing large-scale projects across Africa, the Caribbean, the Middle East, and South and Southeast Asia. As a Black woman working on behalf of Black and Brown people in a predominantly white-led sector, Lazenya's work now focuses on disrupting the status quo, calling out the white supremacist behaviors and neocolonial practices within international development, and offering solutions to redress power imbalances and inequities. She seizes every opportunity to bring attention to health disparities affecting Black and Brown populations. Lazenya, welcome to the Public Health Insight Podcast. Howdy.
Thank you for having me.
Wonderful. So, you recently wrote an article entitled Why I Left My Career in Global Health, which has since gotten a lot of attention. You start off by saying, I entered the global health sector 14 years ago, a giddy 23-year-old ready to save the world. Tell us about the story of this 23-year-old out to save the world. What was the motivation behind it?
Thank you for the question. So by background, I am born and raised in the Caribbean, moved to the UK when I was 12, and most of the people in my class, I started secondary school, they were actually from Africa. And they had just such fascinating backgrounds, such fascinating stories. So I thought, I'd love to visit Africa one day. So fast forward to sixth form, this is just before going to university. And I saw this volunteering program to go and support an HIV/AIDS program in Zambia. And I thought, that would be nice to do that before going to university. But then my Caribbean parents were like, no, you're not doing that. You're not going on a gap year. But my fascination with health, HIV/AIDS in particular at that point, it still remained. So went through, did my bachelor's, wasn't quite sure what I wanted to do for my master's, but then stumbled upon public health, did public health, and then I thought, right, I'm going to go to Africa. So I actually started out doing an internship in West Africa in Liberia. It wasn't an HIV/AIDS program. It was a health relief program. Liberia had just come out of a civil war. So I was supporting with rebuilding the health services in Liberia. And I was supposed to be there for 6 months, ended up being there for 2 years, didn't want to come back home. So then I moved to Haiti and worked there for 2 years in cancer care. I initially said I wanted to save the world, but when you go and you see all of the problems, the challenges, you realize you can't save the world. But a lecturer of mine said it really well, and I keep remembering this. He said, you just chip away at your part, and hopefully everyone else is chipping away at their part, and you'll make a difference to the world. So that was me being giddy 26-year-old, thinking I can do it all of the structural challenges that countries face, addressing that and realizing quite quickly that I couldn't, but I could make a difference in whatever program it was that I was supporting or managing.
That's an incredible story. And I think I remember reading somewhere that you had some interest in pursuing medicine. So I'm curious to hear how your experience across these different diverse settings influenced that transition from like that medical clinical focus to being more of a population health focus.
Yeah. So honestly, my decision to study medicine, it was just, I thought that would be the next best step. My first degree was in biomedical science. So I thought medicine could be next. Now thinking back on it, I'm actually glad that I didn't get into medicine, and you probably read that article. But I just found from doing public health, looking, as you said, at a population level, you can have a wider impact than looking just at one patient on a clinical level. And I'm glad that I was able to do public health and not medicine, because my impact, I feel, has been much further reaching than if I was a clinician. Clinicians do great work, but sometimes they don't look at the system-wide challenges. And for me, that's where my interest is really. How are we shaping, building, strengthening systems so that clinicians can go on and look after their patients.
Yeah, that's an amazing insight. And I think a lot of people, myself included, fell in that boat of the logical next step after studying science in college, university, is to pursue some form or shape of medicine and to understand that there's other ways that we can express our passion for addressing health issues. Even at a systemic level, there's other options beyond medicine. So I definitely appreciate that. And one quote that always sticks out to me when we talk about the intersection of medicine and population health is one from Sir Michael Marmot, and it's why treat people and send them back to the conditions that made them sick. And that's something that's always stood out to me as something that's highlighting the limitations of medicine. Medicine is very important, but also the fact that we have to address the underlying structural and social determinants of health as well.
I think also the immigrant stories also play into it. I didn't have that pressure from my parents to go into medicine, but I think immigrating from Munster to the UK, wanting to be a doctor or a lawyer or a nurse, a position of service, I think that also played into it, even though there wasn't that direct pressure from my parents.
Yeah, that's relatable content right there. Similar to myself and Gordon, at some point during our career trajectory, we thought that was the next logical option, but I never even thought about public health or global health as a potential career in my undergrad. I had no idea that you can have so much impact at that level. You're definitely an advocate for, reaching out and exploring different careers. I know myself and Gordon are, to just highlight the different diversity of careers you could have out there. And you don't necessarily have to be a doctor, lawyer, nurse, etc. to have that impact that you might have as this giddy 23-year-old, right? So
yeah, I don't regret that decision to pivot into public health.
Definitely. But as the title of the article alluded to, things didn't potentially or perhaps go the way you had expected or had hoped. So tell us about those factors that were involved leading up to your decision and why you ultimately decided to walk away from your career in global health as you envisioned it at the time.
Mm-hmm.
Big question.
Yeah. Starting out, I really enjoyed it. As I mentioned, I started out in Liberia, spent 2 years there working on some really interesting projects. Then I moved out to Haiti, stayed there for 2 years, based at the largest tertiary hospital in the country, seeing patients coming from all over the country to get free cancer care. It was the only hospital that provided free cancer care in the country. I think I started noticing a shift within myself when I moved back to the UK. Mm-hmm. So I started my career obviously in low and middle income countries. There were Black people all around me. I saw Black people in leadership. And then I transitioned back to the UK, working in headquarters of international NGOs. And suddenly I'm thrusted into these white spaces, often as the only Black woman in organizations or the only Black person in positions of leadership. And that's where, for me, I started seeing things differently. I think if I had started out my career in the UK, I may have seen them sooner, but I definitely noticed the shift when I moved back to the UK. And I really noticed how white supremacist the sector was. When it comes to the designing of projects, a lot of times I sat in rooms where white people were designing projects that are going to benefit and impact Black and brown people. I tried to now be the voice of, okay, I've lived in these countries, I'm a Black person, like consult more widely, but then being shut down. Just white silence when I would give ideas. And this is me being very senior in projects and saying something, rooting to a conversation given an idea of how we can work more efficiently and just silence, or no one really wants to respond. So after that happening for a while, you get frustrated. Like, it's like you're invisible. So I kept going. I'm like, okay, maybe it's this organization. I'll go to another one. This organization will be different. But then I saw the commonalities. At first I thought, okay, maybe it's me. But then I saw the commonalities and I'm like, no, it's not me. It's how the system was designed. And as I said, I only saw it when I was at the headquarters now in these positions where the power and the influence is. So I felt it more strongly when COVID came with the death of George Floyd. I just had enough. So for my mental health, I said, I need a break. I love it. I love what I do, but I don't like the way that I'm doing it, because I felt being at headquarters that I was now made to operate in the way that headquarters operates, which I find very autocratic sometimes. And that's not how I work. I actually had a manager say to me, you need to tell your country programs what to do. And I thought, no, I'm based in the UK. They're based in their countries. They have the knowledge, the insight, the context of their countries. So no, I won't tell them what to do. So there was this tension that with me and that manager, because that's not how I want to work. So I just thought it would be best at that point to bow out temporarily, get my mind right, figure out how I can re-enter in a way that I'm comfortable. And yeah, so that's why I left. And since then, I've been just quite vocal about my experiences and the practices that I've seen happening within the sector.
Wow. Yeah. Thank you so much for sharing that. And it's really interesting to see that you had that reflection period within yourself too. You're like, is this me? Like, is there something wrong with me? Or then you're doing the shift of testing. Hey, let me check this organization. It's not, something's wrong here. Let's go to another organization. Still something's definitely wrong. You know what I mean?
Yeah.
So I'm kind of interested to dig it a little bit deeper. So with these headquarters in these global health organizations located in these high income countries, right? What are some of their guiding principles? Why do they do the stuff they do? And you mentioned like your manager or upper person told you, hey, you should tell them what to do. Why is that kind of the way things work in these headquarters?
I think a part of it is white superiority. When you look at who is the global health expert within the space, who comes to mind? An older white man. And that is just pervasive within the sector. So it's this assumption that the countries where programs are being implemented, they don't really know how to do it very well, or we know how to do it a bit better, or we have the tools, the resources, the innovation. So it really filters down in how organizations operate. But, you'll see the values on organizations' websites. We value dignity, we value the people that we work for, but in practice, sometimes it's very different. And it's such an ingrained thing within the sector. Like, I don't want to say that it's been done intentionally, but it's just the accepted way that things work. So it's very difficult to challenge that. And that's what I was continually doing. I was challenging that. Why does it have to be a white person who goes to do this training? Why does it have to be that we develop the project, or we have the final say on the budget? Why does it have to be that way? So, after constantly pushing, you get exhausted. So, and they get annoyed, with me. So then there's this alienation that happens. Or before I'm about to speak, you can see, oh, what is she going to say? Like, because she just doesn't leave it alone. Yeah.
Wow. So that's something in of itself that we can unpack. But there's one particular point that piqued my interest. And you touched on it when you first formulated your response. And it was the idea that you got all these experiences and then you moved back to the UK,
Mm-hmm.
high income country, working at headquarters. I think embedded within that as well, based on my observations, hearing you speak, some of the pieces you've written, this is as you were advancing your career while that was happening. So I want to hear from you, did your frustration level increase as you became more of a senior person where you were more prioritizing strategy, and then you're getting closer and closer to leadership, and then you're finding more of those systemic problems that exist, and your ambition and desire to change it was essentially met with a roadblock, and that's something that you found very difficult to overcome, moving away from maybe the super in the program delivery part of things to more strategic. How was that dynamic? How did it play out?
Yeah, that's exactly it. The more senior I became, the more confident that I was, in my ability, my skills, and my experience, the more vocal that I became. And I was able to use my experiences from different countries to see trends and bring this insight to the table. And as you said, just being met with these roadblocks. I felt as well, being in headquarters as opposed to being in country programs, I personally couldn't feel the impact of the work that I was doing as much. It was my choice to move, essentially move back home, but I felt like I was further away from the projects that I was supporting. So I said, okay, let me support then in strategy, in direction, but then having that resistance, having that white silence, having no support, no mentorship back in the UK, it was exhausting, to be honest, and it was quite lonely. It was quite lonely being sometimes the only Black person and sometimes the only woman in these rooms, and that wears on you, and you can take so much, and then you're like, I need to bow out. I have to the pieces that I've written, I've had a lot of people say, oh, we need you back in the sector. We need you back in the sector. And I do want to come back, but I have to prioritize myself. I have to prioritize my mental health. I'm not going to go burn out, give everything, and then there's nothing left to give the other parts of myself. I'm not just my job.
Mm-hmm. And one of the things that stuck out to me as well in some of the articles you've written, especially the one that we're talking about for this particular session, is you pose the question, would I have left if I was a white woman? My honest answer is unlikely. Can you elaborate a bit on why you believe this to be the case?
I felt that white women are quite protected within the sector. And I actually wrote an article, Dear White Women, to tell them what life was like as a Black woman working in the sector. I feel that if I was a white woman, I would have been more protected operating within a white supremacist sector. And I'm going to call it as it is. So the behaviors of, I'm not saying it's all white people, but the behaviors that we see within the sector, the white supremacist behaviors, they're accepted, they're tolerated. So a white woman wouldn't have to do all of this mental work that I had to do. There wouldn't be that white silence that I experienced as a Black woman in a senior position, trying to improve how efficient my project is and just being met with silence. No one's sticking up for me. No one's saying this is a good idea, Lazenya. No one's saying anything. And that example really just sticks in my mind because I had a white manager at that point and there could have been more support. I just feel that there's more support, honestly, for white people within the sector. There's a more clearer career progression for white people within the sector. I felt I've had to do a lot of zigzagging, trying to fit in, whereas a white woman doesn't have to do that. She already fits in. She's at home in headquarters. So I don't think all of the maneuvering that I've had to do, that a white woman would have had to do that. She would have actually just been expending her energy doing the work while I'm doing the work plus all of the other things in the background. So I'm more exhausted than she is. So I honestly don't think that I would have left if I was a white woman for those reasons.
Yeah, that Lazenya, thanks for sharing that and being so open in your pieces. I find them very vivid, honest. I can feel your frustration and it makes it a little bit more relatable. Though I don't work in global health, these are systems that exist more or less everywhere. And we all, as people of color, experience them to varying degrees depending on where we work at. This also had me think about how these systems, white supremacy, actually impacts programming on the ground. And I was wondering if you could share any examples from your experience where those embedded structural white supremacist ideologies have adversely affected the way programs are delivered, who's delivering them, and what were some of those outcomes, if you can speak to that.
It's on many levels, I'd say. So, as I mentioned earlier, there's been times that I am in boardrooms and we're talking about this new project that we want to do. And when it comes to designing the project, the headquarters staff are doing most of the design. And then right at the end, to show that we're being participatory, we're asking the country programs, what do you think about that? Right. So they already have projects brought to them that aren't really inclusive. When we look at the measures for success, so the indicators that are used, a lot of the indicators are to appease the donors, I want to say. They're not really, I would say, culturally important in the country. It's more X number of people received this service. For headquarters and for donors, that's what they want to see. But is that really what the communities that we're serving, is that their measure for success? Is it the numbers, or is it that there's a comprehensive service at their local health clinic? And again, we don't even think about that. Monitoring, evaluation, and learning is the big thing now with projects. You data. But the data that we're gathering, it centers whiteness. It's indicators for success as seen by headquarters, as seen by donors. When it comes to experts, what experts are we flying in? I've sat in workshops where I've had experts from countries that are from the West, from handful countries, and they're delivering these workshops. Great, wonderful, but they have no context of the local environment. And what that does is the workshop participants, they're assimilating the knowledge, but it's like, okay, how do I apply that now when I leave this workshop? So we can have more effective projects, we can have more impact if we actually have facilitators, we have experts from low and middle income countries who both have that technical knowledge, also that insight that someone coming from the West just doesn't have. So I feel like we can be more effective in our programming if we have more localization, if we have more experts from the communities, from the countries, from the region, to be able to speak to specific situations. And then one of the things that makes me chuckle is donor report writing. A lot of my jobs, I've had to write donor reports or be part of teams that write donor reports. So you get the first report from your country program, but by the time that goes to the donor, it's a totally different report. Right. So we have rewritten it to make it look nicer, to make it sound nicer, to make it feel like we're doing a bit more, and again, I feel like that's centering the white gaze. We want to make sure that the donors are happy with it based on how we've rewritten the story as it is. We can't let them know about this challenge because then they might not want to give us that second tranche of funding. So we're telling the donor a story that's very different to what's actually happening. And because it's the language that the donors want to hear, they understand it, they keep funding these projects, but we're not really getting the full story of what's happening in the project. So I hope those were enough examples, but it's right the way from design of project, how project is implemented, how project is reported, that I feel like I see this white supremacist ideology right through.
That's incredibly insightful. And I wonder myself, Lazenya, about just like all we do for social determinants of health, identifying the causes of the causes, asking the question, why? So is it if programs become sustainable, there's less of a need for these donors, and then that impacts what they do strategically? Is the goal to exercise control ultimately? I don't know what the answers to those questions are, but I'm always curious as to why. We've been talking about these things forever, and amazing people like you go in to make a difference and are left frustrated. And if we keep losing ambition and passion and talented people from those space, it's going to make the problem even worse. But at the same time, it's not necessarily your problem alone to fix. You have to prioritize your own family, yourself, and being able to find a space where you feel comfortable and you can contribute positively to health outcomes. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.